Okay, so accompanying symptoms, 4 categories. Inner ear, central, migrainous, and nausea and vomiting. Now we move over to the bedside examination. We have 4 + 4 + 4 tests. And here you see the 4 different tests. So look for a nystagmus. You can use Michael's glasses. You do the head impulse test as demonstrated by the 2 ladies before. What has to be done in every patient, independent of the history, and I will reiterate that at least 10 times, every patient has to be examined by the diagnostic positioning maneuvers. Start with the horizontal canal, otherwise you overlook it, then posterior and then anterior. The next test is, and final one, is the Romberg test. Romberg test, described by Moritz Romberg in 1872. Okay, let's begin nystagmus. What is a nystagmus? We will have a session tomorrow. It comes from the Greek term nystatsein, that means getting drowsy, falling asleep. If you do that in an after-lunch radiology conference in a dark room, there's a slow movement and a fast movement. The pathological one, falling asleep, and eye movements is the slow one. And the fast one brings the eyes back to the primary position. The direction is given according to the fast phase. The most frequent one, of course, is a spontaneous nystagmus. We'll talk about that in greater detail tomorrow. Okay, the next test we do is the head impulse test. And it also works in children, but you should not overdo it, otherwise the mood goes down. So it's a compensatory eye movement, and the VOR generates eye movements with the same angular velocity as the head movement, but in the opposite direction. So that's the basic physiology. And here you see what is happening. There are a few basal things which you have to know. First, the latency of the VOR is very short. That means the delay between onset of the head and the eye movements is only 8 milliseconds. Secondly, there's always an excitation in the direction of the head movement. That means if I turn my head to the right, there's an excitation of the right horizontal canal. If the right horizontal canal is not working properly, the eyes will move with the head to the right, and then the patient makes a refixation saccade. And how the VOR works, you can literally see by a very simple test. Everybody, hold your hands like this. Fixate the nail of your thumb. Keep your head and trunk stable, please. And now move your arm to the right and to the left with increasing angular velocity. How is the image of the nail of your thumb in Indonesia? Is it sharp or blurred? Blurred. Okay, it should be the same everywhere, otherwise you haven't done the test properly. Now do the opposite experiment. Keep the target stable and turn your head to the right and to the left. Okay, how is it now? Crystal sharp. You literally see how the VOR works, and it's particularly relevant during walking, which is a high-frequency procedure, 25 Hertz, and then patients often have movement-induced oscillopsia. So that's the basic function of the VOR, and when you do the test, you have to do it abruptly, small amplitude, and a high angular velocity. Okay, the next test are the diagnostic positioning maneuvers, and during the second lecture, we will discuss them in great detail. The first thing is every patient during every visit. Secondly, start with the horizontal canal. If you examine the horizontal canal, you have to lift the patient's head by 25 degrees to bring the horizontal canal in a vertical position. If you don't do that, neither your diagnostic nor your therapeutic maneuvers will work. If you're 20 degrees away from verticality, the crystals do not move. And for posterior canal, there's a new one. It's called ce mot plus. And for anterior, we have modified that. You see that here on all the slides. And you see this is for horizontal. Posterior, and overextend the head. And this is for anterior canal. So it's very simple. Later on, we will talk about more details of that. Okay, and now this is something we do all together. Please stand up. Don't touch the chair or the table. So we check your early morning balance. Let's see how good you are. So the official way on, well, for the somatosensory system, you can use your tuning fork. Okay, now a brief summary of what we will do tomorrow extensively, the 4 static tests for the oculomotor system. First, you do a cover test to look at a vertical deviation. The next thing is, and this is similar to the vestibular system, look for a spontaneous nystagmus, examine the range of eye movements, and finally look at gaze holding function. I will just briefly summarize this as. Then we have 4 dynamic tests. That means during eye movements, one is smooth pursuit. The other one is a little bit difficult to examine, the saccades. Therefore, that requires some exercise. The next thing is optokinetic nystagmus. Optokinetic nystagmus, that's an elegant test because it examines 2 systems, smooth pursuit and saccades, horizontally and vertical. So it's a super global test. And there's one app which you can download. It's the Optodrum app, which shows stripes moving in front of the patient's eyes. And that's a good global test for evaluating the function of the brainstem. Vertical eye movements, to say that right away, are generated in the midbrain and horizontal in the pons. And if you have a normal optokinetic nystagmus vertically and horizontally, you can be sure brainstem is working perfectly well. And the other test is the so-called visual fixation suppression of the VOR. This you can also exercise now in a few moments. And tonight, after 2 glasses of beer, whatever you drink, it will be impaired. Okay, first of all, a feeling which you probably never had before. That's quite exceptional. Okay, before you close your eyes, please have a look what you should do. So close your eyes, gently touch your upper eyelids, and move your head to the right and to the left. Very slowly. Okay. And now with increasing velocity, can you feel something on the tip of your fingers? What do you feel? Do you feel something? Tuck, 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 tuck. Can you feel something? Yeah, you feel the eyes are moving. You feel in the tip of your fingers your vestibular-ocular reflex. Do you feel it? When I move my head to the right, the eyes move to the left, and then you have a refixation saccade to the right. Now we can check your own visual fixation suppression of the VOR. Cover one eye, gently touch the upper eyelid of the right eye, hold your arms like this, fixate the nail of the thumb, and now move with the same angular velocity, the head and the target, and then you should not feel anything anymore. What the brain is doing with a smooth pursuit system, it generates a signal which is as large as the VOR, but in the opposite direction. This is VOR cancellation, and this requires an intact central nervous system, an intact smooth pursuit system. So it's an elegant test. For your clinical practice, you can use your smartphone in a very smart way. The patient should switch on the camera. The patient should look at the camera and then fixate the camera and doing this. That's a super elegant test to evaluate visual fixation suppression of the VOR. We will do some exercise on that tomorrow. So now we shift to something which is less relevant. Actually, you don't need to have that. If you have it, it's good. It's a good thing to have. And the most important test of the 4 is the video head impulse test, because this allows you to examine the vestibular system quantitatively. And here you see one of the systems. It measures the angular velocity of the head and the eye. Normally it's symmetrical during head turns. and thereby you can quantify the function of the vestibular ocular reflex in the high frequency range. And it's by far the most important test. I have also the video hit in my office, and I always do it on my own. It's very efficient. Within seconds, you have a good idea about the function and the dysfunction. And by this approach, you can easily classify your patients: peripheral, central vestibular, functional, and others are often overestimated. Central means brainstem and cerebellum. What will help you by making the diagnosis very much is what we have elaborated over the last 15 years. International, I call it better, reclassification of vestibular disorders. And take a photograph of the next slide, because this shows the link where you can download for free the diagnostic criteria from the website of the Journal of Vestibular Research.